Evening MRCP Part 1 aspirants and our honorable faculty, Dr. Shilpa Bhartiya ma'am. And today is the class about anemia and general hematology, which would be conducted by her. She is a consultant in hematology, hemato-oncologist and BMT specialist at PARKVIEW Super Specialty Hospital, Kolkata. Her area of interest follows hemoglobinopathy, multiple myeloma, leukemia, and bone marrow transplant. Over to you, ma'am.
Hi, everyone. How are you doing?
Fine, ma'am.
When is your exam?
October.
October this year. Okay. Right. So today I'll be taking a class on anemia and some general hematology. I know they had said bleeding disorders, but the slide deck did not have actual cases related to bleeding disorders. So in the next one, I'll try and make some nice slides for bleeding disorders, and then we'll take on from there. So now this is not a lecture. This is a case discussion, right? So I want you all to be very interactive. There is no point in me talking. So a couple who are expecting their first child presented to the obstetrician and gynecologist for advice. Both parents are known sickle cell trait, HBAS, HBAS, and they want to know if their child will inherit the disease. So quickly go through the options and tell me the right answer. There are too many questions. If I read, we waste time. Anjali Casey. Anjali is a doctor, right?
Yes, ma'am.
Okay, Anjali, your question. Easy one.
B.
25%. Okay, tell me why you have told that. What kind of disease is sickle cell? Is it autosomal dominant, recessive, sex-linked? What type it is? See, without knowing the reason, you are guessing 25%?
No, it is autosomal.
Anybody else? Aman, you will answer. Yeah.
It's autosomal recessive.
Okay, so how is it transmitted, and what is the other person? What 50? Tell me the inheritance. What will happen to 50% of the children in each pregnancy?
If both parents are
50, there is 50% chance of trait.
Okay.
Transmitted.
And
25% of chance of non-inheritance.
Yeah.
And 25% chance of inheritance as it is autosomal recessive.
Perfect. So the wording of the makes it ambiguous, but it is a very typical. There is 25% chance they will get inherited the disease if they get both the bad genes, because it is autosomal recessive fashion. Not inheriting again any of the genes, matlab having HBAA is 25% if both the normal genes go. And if one of the normal and abnormal gene from either parent goes, so 50% chance they will be a carrier. So the genetic counseling can advise heterozygous parents, although there is no primary prevention. If they say, okay, so what is my chance? Should I keep the pregnancy or drop the pregnancy? Because sickle cell disease is not a very nice disease to have. It's not something they can get on. They have lifelong complications and there is a reduced lifespan. We advise chorionic villi sampling either at 8 to 10 weeks of gestation or at 14 to 16 weeks by amniocentesis. And if you can accurately diagnose the child is going to have sickle cell disease, they are given the options. We do not tell them to terminate the pregnancy. They are given the option. In India, it is difficult to manage, but abroad, they are very good sickle management programs, and they can easily manage a child, a person with sickle cell disease up to adulthood. So you always tell them that we will give them the option if they want to continue the pregnancy or not. Okay. So the next question is the mother of a 15-year-old boy. So the mother of a 15-year-old boy. So the boy has got sickle cell disease and she comes to ask advice regarding a vaccination requirements. Okay. This is very important question. He's had all of his childhood immunizations on schedule. So you need to be aware of the UK pediatric immunization schedule, which may differ slightly from the Indian one. Okay. So the question is, which of the following advice the pediatric consultant will give? A, usual childhood is all that you need. You need usual childhood plus yearly influenza and 5-yearly pneumovax. Or you give them childhood plus meningococcal C, childhood plus yearly influenza, and childhood immunization, 5-year pneumovax and pneumococcal. So the next person over here is Dipasri Bhattacharya.
Madam, the answer is B, I think.
Yes. Why do you say that?
Because this, along with the normal immunization, this pediatric age group, they need this pneumococcal vaccine and influenza vaccine.
Okay, tell me, why do these sickle cell people need pneumococcal vaccination? You're not giving to thalassemia, but you're giving to sickle cell anemia. Why?
Also splenectomy.
They are also prone to this pneumococcal infection, madam.
Why do they get hyposplenic? They are saying, no, it should be referred to hyposplenic or asplenic. So when we are planning splenectomy in some patients, not sickle, we give this vaccine. Why do sickle cell patients, why are they hyposplenic?
No, they undergo autosplenectomy.
Yes, correct. Because they get recurrent infarcts and the spleen just gets infarcted on a regular basis and finally shrinks and they become hyposplenic. And we know it's a very important part in getting pneumococcal pneumococcus and meningococcal meningitis. But meningococcal is very well covered in the immunization schedule. But pneumococcal, they need boosters every 5 years and influenza is an annual booster. So this is very important, right? So the next question is, a 32-year-old man has presented with episodic jaundice and anemia and has been diagnosed with G6PD deficiency. On further testing, we know that the wife has got normal G6PD activity, right? So man has got G6PD deficiency and the wife has got normal activity. Which of the following statements is correct? I want Dr. Bihena Suleiman to answer this.
Ma'am, all of their sons will be affected.
Okay, why are you saying that? What is the mode of inheritance of G6PD deficiency?
X-linked recessive, ma'am.
And where does the gene come from? It's X-linked, no? And
Yes,
where does
ma'am.
the gene come from?
From father.
The defective gene is which one?
It's X-linked, sorry.
In an X-linked disease, who is the carrier? Mother or father?
Mother will be carrier, ma'am.
So mother is normal, no? Then why will the son be affected?
Yes, sorry, ma'am. Sorry. So
what will the daughters be affected? Because one X will go from the father, no?
Yes, ma'am. They will be carriers.
Which one?
Daughters will be carriers only.
So you tell me the answer. Choose the answer.
None of their children will be affected.
Right. So you lost this mark, okay? Because of hasty planning. You know it's an X-link, so you said sons are affected. You did not read the question properly. MRCP is not about knowing the thing. It's about reading the question. They will try to confuse you. Okay? So the females are carriers since G6PD is X-linked. Though females are usually not affected. Usually they are not affected because of inactivation of their 1X chromosomes and males are affected, right? So you know X chromosome will be passed on by male to any daughters. Yeah, so the daughters all will have the bad X chromosome, so they will all be carriers. But the good X from the mothers are there. In case of a male fetus, the X is coming from the mother, which is normal. It's the Y which comes from the father, which is normal. That's why all the sons from a father will be normal. It's only sons from a mother can be affected and the daughters from the father will be carriers. So remember, it is opposite. Mother will give to sons and father will give to daughters. Okay. So next question is 62-year-old Japanese gentleman has been started by the GP on quinine for leg cramps. Then 1 week later, he comes with dark urine and 2 days of increasing breathlessness, back pain and fatigue. Investigations are showing his hemoglobin is 7 gram and he's got a raised retic count. So what is the answer?
G6PD deficiency.
Yes. So you have to remember, I don't know, somehow they love this G6PD deficiency because it's got so much interactions and everything. What is the mechanism of hemolysis in G6PD deficiency?
Oxidative stress.
Yeah, so what type of hemolysis occurs, intravascular or extravascular?
Intravascular.
Huh?
Intravascular.
Intravascular. So they get very sick very quickly, right? They get dark urine. So what is a typical color of urine? What is the difference between dark urine of intravascular and dark urine of extravascular? The clinical questions you will ask, no, whether you have yellow urine or you have Coca-Cola colored urine, right? So which one will be yellow? Which one will be Coca-Cola colored? Coca-Cola colored happens in intravascular because of hemoglobin urea, right? So that also you may get a question which will try to tell that. So people of African, Mediterranean, Iraqi, Jewish, Southeast Asian and Chinese, they all have a lot of G6PD deficiency which predisposes them to a hemolytic anemia. Remember the list of drugs that are notorious, yeah? Very commonly they will ask you ecosprin, sulfonamides, antimalarials. Everywhere, if the question is about an African and antimalarial, think of G6PD deficiency because that's what it will be coming up to. And quinine and quinidine, okay? So the hemolytic anemia is non-immune. That means it will be DAT negative, right? Next is a 65-year-old gentleman who has been investigated for a normocytic normochromic anemia. He has been diagnosed with diabetes, mellitus, and hypertension. Hemoglobin is stable around 9.7. His creatinine is calculated, clearance is 43. That means it is low, okay? And the ferritin is 53 and erythropoietin levels are normal. So what are you going to do to manage this patient? That means you should already have made a diagnosis in your mind. Only then you can think of the management. So whoever wants to answer next is going to tell me what the diagnosis is. First, tell me the diagnosis.
Thalassemia.
Thalassemia? Who said that? Who said that?
I did.
Who is that? Sorry, I can't see.
CKD with anemia, I think.
Okay, no, wait a minute, right. No. Whoever said, sorry, I can't see who said. Thalassemia, mein, what is the type of anemia you get?
Microcytic, actually. Hypochromic.
Yeah, absolutely. How can you even think of thalassemia in a 65-year-old gentleman?
No, this is, I think, kidney disease.
Yeah. Absolutely. You see, they have given why you're not reading and understanding the question properly. This is a man with diabetes and hypertension. He's old man. He's having normocytic normochromic. Yeah. He's got a very moderate anemia. Creatinine is obscured. Look at the clear. They've not given you creatinine, but they've given you creatinine clearance is low. That means he has got CKD. And they're telling you he's not iron deficient and his EPO levels are normal. Right? So this man has got chronic kidney disease. You will have to give him darbepoetin. But how will you give darbepoetin? For that, you need your iron. The question is slightly incomplete. Okay, so they have got CKD. You are going to start. This is a renal anemia. Okay. And it is worsened by reduced dietary intake of iron because they don't have, appetite and toxic effect of uremia on the erythroid precursors. There is reduced intestinal absorption of iron. And of course, there is reduced red cell survival. So these patients, you have to give them, if you give just EPO and their iron levels are borderline, it will not work. You want the ferritin, they've said more than 100, but ideally we target more than 200 in the blood. Serum ferritin should be maintained above 200 and only then will your erythropoietin work. So, ideal treatment would be iron replacement followed by darbepoetin replacement, and you want your hemoglobin between 10 and 12, no more than 12, because darbepoetin is thrombotic. You will want to stop it, right? To read the question properly. So next question, 25-year-old gentleman presents with episodic nausea and abdominal pain. So he has maintained a normal weight as per his age and height. These symptoms have been attributed to irritable bowel syndrome, and there are no abnormalities on examination. His blood reports show he is anemic, normal white count, normal platelets, reticulocyte count is high, bilirubin is high, ALT, AST are normal, Coombs test is negative, and haptoglobin is reduced. So what is going on? What is going on, Dr. Mohammed Shah?
Some sort of hemolysis. I think hereditary spherocytosis.
Hereditary spherocytosis.
I mean, the MCV is borderline, like it's normal, I know, but I mean, there has to be some sort of hemolysis over here going on. So the only thing I could see is spherocytosis. I mean, Gilbert syndrome, porphyria. I think it's, I don't know, I think D.
Okay, what in the spherocytosis bit explains the abdominal pain?
No, acute porphyria.
Splenectomy, I thought, might be explain the. I mean, spleen can get this one. Splenomegaly can explain this one, the symptoms. At least that's what I thought.
There are no abnormalities on examination.
Oh, well, we have to read the paper more.
Mm-hmm.
Oh, okay, sorry.
And he is grown normally. And so this is a tricky question, okay? I won't blame you, but you are right. Okay. Your approach is right that there is a hemolytic anemia going on, right?
Yeah.
Now that you know that it is a hemolytic anemia, you know none of them are hemolytic anemias other than hereditary spherocytosis. So go for what your gut instinct says, because nothing else is hemolysis and this is hemolysis. But the reason is you have a mild bilirubin due to a chronic low-grade hemolysis. So you have three features on the blood reports: high bilirubin, high retics, and low haptoglobin. Okay, so HS is the most likely explanation. The two tests, if they ask you, okay, you know, blood film is showing spherocytes. So what are the other tests you can do to confirm? I'll tell you. But the pain is because patients with hemolytic anemia keep getting gallstones, pigment gallstones. Even in mild disease, they may present with gallstones rather than hemolytic anemia. Okay. So the pain abdomen is due to cholecystitis. Okay, so you have to exclude the other features. Rubin-Johnson is conjugated hyperbilirubin. Gilbert's is isolated unconjugated with nothing else wrong. Deficiency in heme causes acute intermittent porphyria, but they get severe abdominal pain and lots of neurological symptoms. Okay, and they have said normal liver enzyme, so you will not say viral hepatitis. So even if you don't know the exact answer, you have to think logically and exclude.
Can you show the question once?
Yeah.
Can you show the? Okay. Okay, sure.
Okay.
Thanks.
So every little word has a meaning behind it. So, you know, read it and read it twice. Next question. This is just a very thin question. You either know it or you don't know it. So mark this one. There's no brain in this. What is the approximate incidence of forming pigment gallstones in patients with sickle cell disease? Again, sickle cell is a hemolytic anemia, no? So any hemolytic anemia, the incidence is increased. The answer is
50%.
Just remember it. I don't know what the logic is, but just remember that it is about half the patients will get gallstones. Okay. So next question is 45-year-old gentleman, medical ward, received a transfusion 48 hours early for a symptomatic anemia because he had CKD and COPD. Okay. So he had a blood transfusion for whatever reason. He gave a history of previous transfusion also last year. CKD may be required transfusion last year also. So 48 hours after receiving transfusion, he's dropped his hemoglobin by 20, means 2 grams per DL compared to the pre-transfusion level. And he is reporting a dark colored urine. The LDH and bilirubin have increased. So tell me what has happened. Answer, Ajay Jyotish.
I'm not sure, ma'am.
Acute hemolytic transfusion reaction. 48 hours after. Delayed hemolytic transfusion reaction.
Yeah. So again, what did I say? Every letter is important. If it happened within half an hour, then your answer is acute hemolytic transfusion reaction. Transfusion तो हो गया 2 दिन पहले घर जाके उसको reaction हुआ. So can you call it acute? You can't, right? And it's not a febrile reaction. It is a hemolytic reaction, because if the hemoglobin was 8, after giving blood, it should go to 9, no, but it has become 6. That means whatever blood you have transfused has hemolyzed and you've got dark colored urine with high LDH, high bilirubin. These are very classical features of hemolysis. So it is a delayed transfusion because it has happened after 48 hours. Okay. And why it will happen? Because why did it happen? Okay. There we go. The answer is 48 hours, but why did it happen? Again, is there any importance of them telling in the question that he is giving a history of previous transfusions last year? That means he has got sensitized to something in the blood last year and he's developed antibodies. Okay. Again, while transfusion this year, he got re-exposed to those antibodies and he has hemolyzed, right? So people who have been previously immunized either by transfusion or pregnancy, the initially antibodies are not detectable, but when you give a second immune response, they come in a big way and they cause transfusion reactions. It's important. All of you transfuse blood, right? You should be aware of these side effects. So what are you going to do? CBC, check the blood film, LDH, Coombs test, creatinine, bilirubin, haptoglobin, and urine for hemoglobinuria. This is a hemolytic panel. Whenever they are giving a combination of these tests in your question, understand that there is hemolysis. Now, what the reason may be due to hemolysis, that you have to work out on other data. So you have to recheck the group and antibody. Is it what type of antibodies they have developed? Given the time frame, you can't get GVHD and it's not acute hepatitis. Again, acute hemolysis occurs during transfusion, and we know it's a delayed transfusion. Any doubts so far? Please stop and ask me. Don't sort of keep carrying on even if you haven't understood. Nothing is silly in hematology. It looks straightforward, but it can be very complicated. So please, I'm urging you, if you need to don't understand anything, please stop me and ask. Shall I move on?
Yes.